Good morning, everyone. Today's pre-conference will focus on key musculoskeletal and integumentary conditions that frequently will appear on clinical floors and your NCLEX. So we will cover common orthopedic injuries, post-op complications, and also critical skin and wound care concepts for this pre-conference for this week. And then we'll start with cardiac and vascular for next week. Okay, so for fractures, again, I always like to start with pathophysiology. So it's a break in the bone continuity, right, due to trauma, osteoporosis, or just simply from overuse. So healing in this element will require alignment and stabilization. So for your diagnostics, you're going to use X-ray, which is usually primary. And then you can also use CT and MRI for complex fractures, hard to find fractures. Clinical manifestations, you'll have pain, swelling, and deformity. You also may have crepitus and limited range of motion. And then possible neurovascular compromise as well. Nursing management, you're going to do the neurovascular check, so your 5 Ps, you always want to remember that. So pain, pallor, pulses, paresthesia, and paralysis. So you'll want to elevate the limb, apply ice for the first 24 to 48 hours, and educate. You don't want to stick any types of objects down any cast, okay? Pin care with traction, so sterile and monitor for infection. For traction, we don't see it often. Again, I've only seen it done twice. For traction, you have skin and also skeletal. So either way, you're going to want to maintain alignment of the limb. The weights do hang freely, okay? So you'll monitor pressure points of those weights. So NCLEX tip for this, if the patient reports unrelieved pain after medication, you're going to want to suspect that they are having some type of compartment syndrome, and you'll want to notify the provider immediately. Okay, next we'll talk about hip fractures, ORIFs, and total hip replacements. So pathophysiology, this is common in older adults due to osteoporosis, a high risk of complications with these surgeries, immobility, DVT, pressure injuries, pressure ulcers as well. So ORIF, it's an open reduction with internal fixation. So this means the patient is having surgical alignment, okay? So they're going to have pins, screws, or plates. And then THR, also known as total hip replacement, is a prosthetic replacement, typically of the femoral head and or acetabulum, okay? So you'll need to know, bones, you'll need to know what connects to what as well. Really important that you know your bone anatomy. So for post-op nursing care, you're going to avoid hip adduction, again, not hip adduction, okay? So flexion over 90 degrees. You don't want them crossing your legs because it puts them at risk of dislocating that hip. So you're going to use the abduction pillow. They're going to use an elevated toilet seat. And you're also going to think, too, incentive spirometry, DVT prophylaxis, SCDs, or anticoagulants such as Lovenox or heparin. NCLEX tip, sudden severe pain if they have a shortening of the leg and external rotation, that is an emergency, and that means that they probably have dislocated their hip. Okay, next we have compartment syndrome. I'm sure you have all heard of this before. So pathophysiology is you're going to have swelling in the limb, which is going to increase pressure, decrease perfusion of that limb, and it's going to cause ischemia of the nerves and muscles. And it's also very painful as well. So your patient is going to say, oh man, I know you just gave me 5 of oxycodone, but this pain is unrelentless, like it's not letting up at all. Okay, so your patient will have unrelieved pain, they'll have pallor, pulselessness, paresthesia, and paralysis. Again, so those 5 Ps. The pain is disproportionate to the injury. Okay, so if it's surgical pain should be relieved with like a low dose opioid. Sometimes even Tylenol will relieve that. But if you're finding you're giving this medication that is appropriate for the type of surgery they've had or injury they have, and it's just not letting up, you need to call the doctor. So as far as nursing actions, you're going to want to remove or loosen a cast or dressing. Obviously, you'll notify the surgeon immediately, and you're going to prepare for a possible fasciotomy, okay? So for critical thinking, your cue should be, okay, compartment syndrome, it's a limb-threatening emergency. So you don't want to elevate or ice and limb with suspected compartment syndrome because it'll reduce perfusion further. Okay, so next we have rhabdomyolysis. Pathophysiology for this is you'll have muscle breakdown, and that muscle will release myoglobin, and that will cause renal failure. Okay, so you can have crush injuries, prolonged immobilization if your patients are on statins for maybe high cholesterol. So atorvastatin, rosuvastatin, simvastatin, lovastatin, and also it can cause seizures as well. So signs and symptoms, your patient will have tea-colored urine. They'll also complain of muscle pain and weakness. That I feel like is usually the most common symptom. Also patients who are all of a sudden having falls and complaining of weakness. And if you look in their history and they might be on a statin, that's something to consider. This can happen to patients even if they've been on statins for over 20 years. So this could happen at any point of them taking that medication. They'll also have an elevated CK, potassium, and creatinine as well for your labs, okay? So nursing interventions, you're going to do aggressive IV fluids to prevent renal failure, right? Our kidneys love to be hydrated. You're going to monitor urine output and their electrolytes, and also they may have to be on possible dialysis short term if acute kidney injury does develop. So for rhabdo, you're going to think muscle death equals kidney risk. Okay, next we have fat embolism syndrome, also known as FES. So for the pathophysiology for this, you're going to have fat globules from the bone marrow enter the bloodstream after a post-long bone fracture. So anytime your patient presents with a long bone fracture and they have like respiratory distress, neural changes, you're going to want to think of a fat emboli, okay? So they'll have a triad of signs and symptoms. So it'll be hypoxemia, respiratory distress, neurological changes such as confusion, like I said, and then petechiae. It'll be on their chest, axilla, or conjunctiva. Nursing care, you're going to do high flow oxygen. You'll raise the head of the bed. You'll want to call a rapid response, and also you can use corticosteroids as well if needed. Some long bone fractures, just to give you guys some examples. So your femur, your thigh bone, your tibia, which is your shin bone, your radius, which is your forearm bone, and your ulna, which is your other forearm bone. So just keep those in mind. Obviously, we have a lot of bones in our body, but those are the four most common that you'll see with that scenario. So for your NCLEX tip, confusion plus dyspnea post a long bone fracture, you're going to think of fat embolism syndrome. Okay, so for wound complications, this will include dehiscence of a wound, evisceration, and also infection. So prevention, you're going to want them, and you're going to teach your patient to squint while they're coughing. Early ambulation, you're going to monitor drainage. Remember, color, amount, odor, intake, and output. Okay, especially when you guys are giving oral report, I'm finding that you're saying, oh, well, they have a chest tube. Okay, well, what does the drainage look like? They have 200 of serosanguinous. Okay, we're not really concerned. Now, if I said like frank red blood, that would be more concerning, right? So just be a little bit more descriptive when you're talking about drainage. Interventions, if it's an evisceration, you're going to cover with sterile saline soaked gauze. You're going to tell the patient to have their knees bent, and you're going to call the provider immediately. And then obviously for infection risks, increase in diabetic, obese patients, malnourished, and steroid-treated patients as well. So just some things to keep in mind, some concepts to take with you to clinical. Okay, pressure injuries and skin integrity. This is something that you're going to have to know through and through. You're going to see a lot of pressure injuries and skin integrity, and you're also going to see a lot of interventions. If you have the chance to see wound care on your unit, pick their brain, ask them questions, and see what recommendations they have to prevent these injuries, because this does cost our healthcare system a lot, because it either prolongs hospitalization or patients end up having secondary infections or secondary reasons why they are still in the hospital and not able to go home. So for the stages, stage 1 is going to be red and non-blanchable. Stage 2 is a partial thickness, so you'll see blistering. Stage 3, full thickness, fat will be visible. Stage 4, exposed bone and muscle. So unstageable, it's covered with eschar slough. And then deep tissue injury is that purple discoloration that we'll see. So prevention, Q2 turns, floating the heels, ordering specialty mattresses if needed, nutrition. So really, you want to make sure your patient's getting enough protein, zinc, and vitamin C, right? You want to make sure that they have consults with dietary and nutrition as well. For care, stage 1 and stage 2, keep clean. You'll want a moist dressing. For stage 3 and 4, you're going to want to consult wound care, and then they may also need possible surgical debridement if it's that bad. For NCLEX tip, you'll use the Braden scale for the risk, right? So if a score is less than or equal to 18, that patient is considered high risk. Okay, so as nurses, our early detection and prevention skills, obviously can prevent life-threatening complications. So you'll want to think critically, anticipate complications, and use your assessment tools. So you'll always want to assess, right? We always assess before we act. You want to know your red flags, so unrelieved pain, sudden confusion, petechiae. You want to prioritize ABCs and safety as well. And then also don't forget the post-op positioning that we talked about to prevent hip dislocations.